Jacob. Today, I'm really excited about our topic. It's a little different. Jacob recently saw this paper and said, we basically got to do a podcast. Hey, Jacob.
Your audio sucks.
Yeah, you kid. Who's mine?
My audio? I
No,
haven't even said
Jacob's.
anything yet.
Jack, all I hear is
No,
like background noise from Jacob.
Seriously, it's just like the kids
Background
yelling.
noise.
Is that what you're hearing?
Mm-hmm.
Yeah. How
Hold
many
on.
kids you got there? Like 20 kids?
Like 25. Hold on a second. Let me see if I can fix this.
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
Yeah, we can definitely do that, or we could be better clinicians and use our ultrasound.
Hello, everybody. Welcome to the Ultrasound Podcast with Matt, Mike, and Jacob. I'm really excited about the podcast today. Jacob recently sent us an article and said we've got to do a podcast about this. And after reading it, I agree. This is an incredible article that kind of shows how powerful ultrasound is. This podcast is a little different in that we're not actually going to teach you how to do any scans. If you want to learn actually how to scan, then come to one of the courses we do. Come to Cabo or come to Castle Fest. And speaking of that, I meant to mention this at the very beginning of the podcast, but we've been getting a lot of emails from students and residents asking if we've got a student rate. And we don't normally do that, but we decided we would do even better. We're going to give a couple of scholarships away. So if you want to come to Cabo Fest, tweet to us at UltrasoundPod or just email me at matt@ultrasoundpodcast.com. And we're going to pick one resident and one student to come completely free. So go ahead and tweet that. We'll give you a second now. Go ahead. I see you typing away on your phone. Great job. Now back to the podcast. Today, although we're not going to actually be teaching you how to scan, we're going to talk about how we use ultrasound kind of in real life when we see an undifferentiated sick septic patient and we don't really have a focused question. We just need to know what in the world is going on. What is going on with this patient? We have no idea. And this study really shows the power of ultrasound to help you make that diagnosis in these really sick patients. The numbers are staggering, not to spoil it for you. So Jacob, talk to us about this article.
All right, so we're going to talk about basically it's going to be sepsis and ultrasound, and we're going to talk about it specifically in the context of this article right here. Now, this article is entitled The Accuracy of Point-of-Care Ultrasound to Identify the Source of Infection in Septic Patients, a prospective study. It was done in an Italian emergency department in Milan specifically over a period of 6 months. They enrolled a bunch of patients, so consecutive actually patients, that they say that in their ED, all of their physicians use ultrasound in the diagnosis of sepsis, which is kind of cool. So what they did is all the patients who came into the emergency department that met their surviving sepsis campaign criteria for sepsis, and that is the presence of infection together with two or more systemic inflammatory manifestations of that infection. So what they did was they identified patients with sepsis, and a physician got an initial clinical assessment, which was the history, physical examination, an ABG, and a lactate. At that point, they had to decide on a provisional diagnosis of a septic source. So they had to basically decide right then. And they called that T0. Then that same physician, so the same one that did the initial workup, did an ultrasound and came up with a point-of-care ultrasound implemented diagnosis and called that T1. What was cool is that all the ultrasound examinations were done within 10 minutes of that initial evaluation. So after they did the ultrasound, they could not change the diagnostic workup, but they could change the therapeutic pathway established at that T0 based on what the ultrasound showed.
Which is maybe not that important because really this is more of a diagnostic study, not necessarily a therapeutic study, right?
Agreed, but what some of the previous studies have done is they've actually done it where the ultrasound, even though it's done, doesn't change what the pathway is for the patient, right? So if like you thought the patient had a UTI and the ultrasound showed pneumonia, other studies have said, well, you have to keep treating it as a UTI rather than that pneumonia that the ultrasound saw, which actually makes sense because they said that they had to change what they did based off of an ethical, kind of dilemma. Like if you know something is different, you got to change it. Makes sense. Now,
and these guys just trust their ultrasound a little bit more than some of the previous people who've done these kind of studies.
Right, exactly. Now, the gold standard was 2 emergency medicine physicians who were blinded to the ultrasound, and they were basically made a diagnosis based off the chart review. So these are the things that were in their algorithm: pneumonia, endocarditis, cholecystitis, liver abscess, septic arthritis, ascites, infected kidney stone, appendicitis, diverticulitis, abscess, or renal abscess. This is basically what they were looking at. Now, if somebody had like a cough or fever, they just kind of started with the heart and lung, and if they had a diagnosis, they stopped there. But if they didn't really know what was up, they just looked at all of these things kind of together. And they basically compared ultrasound at the diagnosis of all those things versus the history of the physical, an ABG, and a lactate.
What do you mean those were the things were in the differential? I mean, because there are a lot more things that can cause sepsis. These are just the things that they decided we'll look for these with ultrasound.
Exactly. These are the things basically they decided that ultrasound can diagnose or can rule out. And I'll talk about it more later. One of the things that ultrasound can't do is it can't diagnose a UTI. So they only looked for things that they could actually diagnose, which makes sense.
And I imagine that they sort of directed their ultrasound based on the physical exam findings, right? I mean, because you're not going to look at every joint to look for septic arthritis. You're going to look at the hot, red, inflamed joint, if there is one.
Yeah, agreed.
I'm a little disappointed they didn't at least consider putting a urine dipstick on the end of the probe and letting the patient pee on the probe, just to include that as well. But I guess this is a pretty good list otherwise.
I've also heard you can look at the ureteral jet and see if it's faster than normal, and that can suggest pyelonephritis.
Exactly.
That's right.
Future studies.
Yeah, we'll get there.
Yeah. So they ended up enrolling 200 consecutive patients. They were mostly a little bit older. The mean age was 64.2 years of age, and 71 out of 200 of their patients, which is 35%, met diagnostic criteria for severe sepsis or septic shock. The rest were just regular sepsis. So honestly, for the majority of emergency departments, what is more likely to present to the emergency department? So these are their results. Now here's a little chart here, and it compares ultrasound on the left side versus not ultrasound on the right. And you look at these numbers, and it's pretty impressive how well ultrasound did compared to not using ultrasound. Now, Matt, do you want to tell me how likelihood ratios work? Do you remember that? Remember we talked about it?
Oh, geez. Big numbers are better than small numbers.
Nice.
Yes. These likelihood ratios, positive ones over 10, are really good for ultrasound, and a 3.5 is just not that good.
I'm confused though. So what is this likelihood ratio telling me? Does this mean that overall ultrasound has a positive likelihood ratio of 16.1, or is this specific to a unique diagnosis like pneumonia or endocarditis or something like that?
So
or is it just all comers?
This is actually all ultrasound. This is ultrasound as a whole, and they don't have the data extracted, but they talk about it in the article how there were certain ultrasound diagnoses that ultrasound was a lot more accurate for. For instance, the sensitivity for pneumonia was almost 100%, but when they're looking at some of the other findings, the accuracy wasn't quite as good. They don't mention specificities or likelihood ratios of the different examinations separately, but this number, these 16.1, is all comers. So diagnosing a septic source, it has a positive likelihood ratio of 16.1. And
the numbers for those specific ones are things that you would think. They had pneumonia, 90%, soft tissue infections, and cholecystitis, 80-something%,
Right.
and then appy and diverticulitis, 60-something%. So, yeah, and I think the fact that it seemed like there were a lot of pneumonias in this study, so that definitely helped. And that's real life. We've got a lot of pneumonias.
So basically, if you find a diagnosis on ultrasound, that's the diagnosis because you've got a high positive likelihood ratio, right? So
Exactly.
it just shows you your confidence in the diagnosis that you've made on ultrasound. Although the likelihood ratio is not bad, it's pretty good. What is a cutoff for a good negative likelihood ratio, Jacob?
It's a 0.1, and that negative likelihood ratio of 0.28. It's not quite 0.1, but it's almost there, and it's better than not using ultrasound. I mean, significant. It's like twice as good as the not ultrasound group.
Yeah, the specificity is what's really impressive, though, here. You find the diagnosis and you're done. They weren't perfect because they had, what was it, like one abscess that ended up being malaria later?
Yeah, exactly.
Something crazy like that.
Yeah.
But otherwise, they found it and they were done. If they didn't, they kept looking. The problem, though, Jacob, is they're adding, I mean, this is a time-dependent thing. They're doing this test. They're adding time. Are they slowing down other things? How quickly are they able to make these diagnoses? How did this affect kind of the overall care, and how quickly the patient gets antibiotics?
What if they're getting in the way of that portable chest X-ray?
Right. Or that blind ABG on the obese patient. You know, what if ultrasound's getting in the way of that? Yeah, so that's a really good question. Now, besides the fact that ultrasound was so good at diagnosing things compared to not using ultrasound, one of the things that was most impressive is the time it took. Now, ultrasound, all of their patients that they did, ultrasound came up with the diagnosis in less than 10 minutes. So 10 minutes is the longest that it took to figure this out. So if you look at this chart here, it shows that if you hadn't used ultrasound, only 22% of the patients enrolled would have gotten a diagnosis within an hour using that standard approach. In 15.7% of the population, so that's 28 out of the 178, septic source identification took longer than 24 hours. That's a really long period of time.
Why does it matter though, Jacob? I mean, we know what to do with these patients, right? Like, we're going to give them fluids, we're going to admit them to the ICU, I guess they'll get some antibiotics. Like, do we really even need to know what the diagnosis is, I guess is my question.
There's an important word in the surviving sepsis guidelines, and that is appropriate. They recommend appropriate antibiotic treatment be started within a maximum of 3 hours from the initial patient evaluation. So yeah, we could just throw, vancomycin and levoquin on all of our patients, but that's not probably the best medicine that we can be practicing. I mean, if someone, has a community-acquired pneumonia, we got to be treating that specific bug depending on the antibiogram of wherever you're living. Same thing if it's a UTI, same thing if it's an abscess.
So you want the right diagnosis, and I think those numbers are impressive enough to repeat. You said without ultrasound, they had the right diagnosis in less than 1 hour, 21% of the time.
22.
In 3 hours, 21.9, I'm sorry. In 3 hours, 52.8% of the time. In 6 hours, 71% of the time. So in 6 hours, they got the right diagnosis 71 times. And with ultrasound, in 10 minutes, they were at 73%. So they were better in 10 minutes than 6 hours without ultrasound.
Right.
That's pretty amazing.
Yeah, those are powerful numbers there.
I was just going to say, didn't you mention, Jacob, there was some sort of change in antibiotic choice?
Yeah, so if you look at where they started antibiotics based off their initial treatment, when they added ultrasound, so when they did their T0 and then they did ultrasound, which is that T1, they actually changed their antibiotics 24% of the time. So it's almost a quarter of the patients actually had the wrong antibiotics initially and would have gotten the wrong antibiotics if ultrasound had not been used.
That's really impressive. You know what this reminds me of? This reminds me of the rush exam.
Yeah.
This reminds me of a totally undifferentiated patient who comes in and you do your physical exam, you do your initial assessment, and then you use ultrasound to really give you the true answer, and you get it super quickly, and it alters the care of the patient. I mean, this is a really impressive. These are impressive numbers. I mean, I guess we need to reproduce this probably, but man, that's like 25%. That's a quarter of your patients where you're changing your antibiotic choice just based on a 10-minute ultrasound. Wow.
Yeah, and I really like the number, that 22% improvement in accuracy with ultrasound. That's a pretty big jump. And it reminds me of my experience. We've all seen these sick patients. I remember as a resident, very young resident, when I had a really sick patient come in, after about a year of residency, I had started to learn to grab the attendings who were good with ultrasound when I had a sick patient, because I didn't realize that they were maybe 22% more accurate, but that's just kind of the feeling I got. I saw them make diagnoses that the other attendings weren't making. And it's really nice to have that number now, 22% more accurate with ultrasound in these sick septic patients.
And I think like the constant feedback from using ultrasound in that manner makes you just a better clinician anyway without ultrasound, because you make the diagnosis, the correct diagnosis, more quickly and more regularly. So you get used to what the patient's presentation is. Otherwise, these patients who there isn't a diagnosis made for, 16, 24 hours, they're already in the ICU. You've forgotten about them, gone home, and you don't have that feedback. But ultrasound gives you that 10-minute feedback as to what your patient's true diagnosis is. And I think it just makes you a better doctor.
It's that immediate feedback loop. You have hypothesis, test, answer, yes, no, and then you make a new hypothesis. It definitely, I think I agree with you. It makes you better with your history and physical exam because you're getting confirmation immediately. Now, one of the limits of this obviously is going to be that they didn't really test mortality to benefit, patient-centered outcomes, but these are pretty impressive outcomes, getting the right antibiotics quicker, the things that we have solid guidelines on. What other limitations were there in this study?
Well, Mike, you kind of touched on it already. It was a single-centered study, and these were not novices in ultrasound. These are people that were pretty advanced on their ultrasound. Like, I actually recognize at least half of the authors as people who had previously published other ultrasound articles. So these were advanced users, that's one thing. It was a single-centered study, and there was no kind of randomization, so they didn't know if they just completely didn't use ultrasound, if one group would have done better than the other. But they state that they felt ethically obligated to not randomize because they all use ultrasound already in their daily practice.
Also, the timing of the diagnosis of the sepsis outside of the ultrasound arm was sort of chart review-esque, right? They're looking back at the chart and trying to decide when you would have been able to figure out what the patient source was based on other testing. So, maybe a little bit different, but just, even if you look at, T0 versus T1 and you look at the difference in diagnosis there, to me, if we're talking about correct antibiotic administration, the earlier I can choose the right antibiotic, the better. And whether it takes, 3 hours or 16 hours, that's still a meaningful difference in choosing the right antibiotic for sure.
But it sounds like the biggest limitation is that these were experts, and so you really couldn't repeat this. at another hospital, which is a great point because there's absolutely nothing that you can do to just get better at it yourself. Right?
No, there's no way. I mean, you might as
You're
well
not
give
good
up.
at this. Yeah,
Yeah.
patients are doomed.
Yeah.
Nothing you do.
Yeah.
No, I mean, seriously,
Yeah.
we say this over and over. Go learn this, all right? We talk about our courses. Come to one of our courses, but there are courses everywhere. You can just look this up and go to one close by. If you can't travel, join the Ultrasound Leadership Academy. Get your own ultrasound machine, learn in a year-long fellowship. If you can't afford that, we give scholarships for resource-limited fellows all the time for ULA. Or if you don't want to travel, you don't want to join something like that, just watch online. There are resources everywhere. There's absolutely no excuse now for not learning ultrasound. There are
I'm
tons
really
free
tired of that
videos out there.
limitation. I'm really tired of that limitation constantly saying that, like, well, these were experts. So, and then you hear people talk about that and they're like, yeah, we probably couldn't do that at our institution because these were experts.
Yeah.
But we constantly hear that. That's
very
like
annoying.
every single ultrasound article is, the limitation was these were experts performing ultrasound. Like, who cares, man? Like, that's like saying, like, these were better trained physicians that take better care of patients. Therefore, we could never try to be as good as them. It doesn't make any sense at all.
And I think it's so common because it probably 10 to 15 years ago, it was probably a valid excuse. It wasn't completely free, so easy to get education if you just sought it out. But now there's absolutely no excuse for it. There's plenty of ways to learn how to do this. Everybody can do it at this point.
One of the ways that I'd always tell people, and people come to me and say, well, how am I going to learn this? And the best way is if you don't really have someone that can teach you, you don't really have a champion in your institution that can help you with the ultrasound, you have a patient that you see that pneumonia on that CT scan or that x-ray, go back with the ultrasound transducer and see what it looks like. You have that patient with a pneumothorax that you've diagnosed him with a pneumothorax, go back and look what it looks like, go back and see what it looks like. Abscess, basically all of this stuff, go back afterwards. In the thousands of ultrasounds I've done, I've only ever had a patient tell me no once when I asked if I could do an ultrasound, even after the diagnosis was made. Patients like it, you're spending more time with it, and you're going to be learning.
Because ultrasound is image recognition, it's not rocket science. Like, really all you need is that initiative to go forward and use it on as many patients as you possibly can. And it's impossible not to become, an expert at this in a very short amount of time.
And the way that I do this and tell others too is you don't even really have to ask the patient, hey, can I ultrasound this finding? You have, and I hear people complain all the time, I don't have time to do this on a busy shift. Well, you have to go in and tell the patient their diagnosis. So when you go in to tell them, take the machine with you and don't tell them, but show them.
Mm-hmm.
Take the machine in and say, hey, I brought this machine in because I want to show you what's wrong with you, and scan it with them. They think you're doing it for them. They love it, but you're actually doing it for your own education. No extra time. You get that benefit. You get the patient satisfaction bump. Everybody's happy. I think that's one of the best ways to get that big pathology bank in your brain. Jacob, that was a great choice. It was an awesome article. Powerful numbers. Hopefully everybody's going to go do this. And we talked about a lot of different scans, pneumonia, things like that. And if you do want to know how to do those as well, this fall, we're going to have a series of actually kind of basic how-to videos on things that maybe we covered a couple years ago, maybe not. But look for that pretty soon in the fall. And again, if you're a med student or resident, remember, email us, tweet to us, come to Cabo with us. If you want to check out what it is, CaboFest2017.com, CastleFest2017.com. Go check out those. If you want to come to one of those, email us and let us know, and we're going to pick a couple residents and med students to come for free because we love you.
Nice.
Hey, one more thing about Cabo. We've added some phenomenal instructors, and we never really mentioned them. Mike, Jacob, Haney, and I, as you know, are going to be there. The Mike Stone, Nerve Block Wizard, Chris Fox, Jean-Francois and Maxime, Andy Slose, Taryn Trott, Steve Bunch, Miley Alvarado. It's going to be an incredible course. Amazing instructors on the beach. CaboFest2017.com. See you then.
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
Yeah, we can definitely do that, or we could be better clinicians and use our ultrasound.
Bye.